Podcast 4 of the Pelvis and Perineum series, the bladder and reproductive organs. This podcast is going to outline the anatomy of the bladder and also the male and female reproductive organs within the pelvis. So to start the podcast, let's begin with the bladder. The bladder is a hollow muscular organ and is capable of considerable distension. It receives urine from the two ureters that drain the kidneys and acts as a temporary reservoir. When the bladder is empty, it is located in the lesser pelvis, immediately posterior to the pubic symphysis and pubic bones, and it sits on the pelvic floor. When the bladder fills, it can extend into the greater pelvis and rub against the anterior abdominal wall. Sometimes it can be observed to reach the umbilicus. The bladder itself is a boat-shaped organ with an apex, body, fundus and neck. It also has a superior, posterior and two infralateral surfaces. The apex of the bladder sits against the pubic symphysis and is a site where the median umbilical ligament extends from the bladder to the anterior abdominal wall. This median umbilical ligament is the remnant of the urachus which extended from the apex of the bladder to the umbilicus during embryonic and fetal development. Opposite the apex is the fundus, and this is formed by the posterior wall of the bladder. The body of the bladder is found between this apex and the fundus, with both the fundus and the two infralateral walls converging inferiorly to form the bladder neck. The walls of the bladder are mostly made up of detrusor muscle, with the superior 2/3 of the internal bladder surface being elevated into rugae. These folds allow the bladder to distend when filling. The inferior third is smoothened and is known as the trigone. This trigone is a triangular-shaped area that has the opening for the two ureters and also the opening for the urethra at its three angles. The two ureters open obliquely into the bladder and are surrounded by fine muscle fibres that contract during bladder emptying to prevent the backflow of urine into the ureters. Leaving the bladder from the internal urethral orifice is the urethra. This is a muscular tube that is obviously considerably longer in the male than the female. The male urethra extends from the internal urethral orifice to the external urethral orifice at the tip of the gland's penis. By doing so, it passes through the prostate gland, then the deep perineal pouch, and it enters the corpus spongiosum of the penis. As well as carrying urine, the male urethra is also responsible for carrying semen during ejaculation. When the penis is flaccid, the urethra has a double curved pathway and can be divided into 4 parts: the intramural or preprostatic, the prostatic, the intermediate or membranous, and finally the spongy part. The intramural part of the urethra extends vertically through the neck of the bladder and is surrounded by the internal urethral sphincter. This is a smooth muscle sphincter that is absent in females. It is important in males in that it prevents semen from travelling into the bladder during ejaculation. As the urethra passes through the prostate, it becomes the prostatic urethra. Here the urethra is at its widest and has some characteristic features, with the most prominent of these being the urethral crest. This is a median ridge with bilateral grooves known as the prostatic sinuses. Opening up into the prostatic sinuses are the prostatic ducts, and these deliver prostatic secretions into the urethra. In the middle of the urethral crest is a rounded eminence, the seminal colliculus, and this contains the prostatic utricle. This is a small opening that is the homologue of the female uterovaginal canal. On either side of the prostatic utricle are the two ejaculatory ducts, and this marks the union of both the urinary and reproductive systems. As the urethra passes through the prostate, it then runs forwards to become the intermediate or membranous urethra and enters the deep perineal pouch. Here it is surrounded by the external urethral sphincter, and it then goes on to pierce the perineal membrane. Once through the perineal membrane, it then takes a rather tortuous route as the spongy urethra, where it courses through the corpus spongiosum and receives secretions from the bulbourethral glands. The spongy urethra then extends to the external urethral orifice at the tip of the gland's penis. The female urethra is shorter than the male and is not divided into 4 parts. It leaves the bladder via the internal urethral orifice and passes alongside the vagina through the urogenital hiatus of the pelvic diaphragm. The external urethral orifice opens up in the vestibule anterior to the vagina. The female urethra doesn't have a well-organised internal urethral sphincter and heavily relies on the muscular pelvic diaphragm and the external urethral sphincter of the urogenital diaphragm to achieve urinary continence. Either side of the external urethral orifice are a pair of paraurethral glands that open into the urethra, and these are the equivalent to the male prostate. As the female urethra is much shorter and more mobile than the male, catheterization is much easier, but the risk of urinary tract infections as it opens to the exterior via the vestibule is increased. So now let's move on to the reproductive organs and start by looking at the male. The male reproductive tract is responsible for producing and transporting sperm to the female ova in order to reproduce. The male reproductive organs are located both externally, including the testes and part of the ductus deferens, and also internally, including the ejaculatory ducts, the seminal vesicles, and the prostate gland. Although the testes are physically located externally, they can be referred to as the internal reproductive organs due to their original position during embryonic development and their homology to the female ovaries. So the testes are the male gonads. They are located in the scrotum and are responsible for producing sperm and also producing hormones like testosterone. Within the scrotum, the testes are separated by the scrotal septum, and each testicle is suspended within this sac by the spermatic cord. Each testicle is surrounded by a series of membranous layers. There's the tunica vaginalis and the tunica albuginea. The tunica vaginalis is a double-layered membranous sac that forms a similar arrangement to the pleura around the lungs. There is a visceral layer, which covers the surface of each testicle, and a parietal layer, which is adjacent to the internal spermatic fascia. There is a small amount of serous fluid between these layers, which enables the testes to move freely within the scrotum. The double-layered tubica vaginalis represents the embryonic processus vaginalis. If you remember, this was the peritoneal outgrowth that extended into the scrotum, taking with it the layers of fascia and muscle from the anterior abdominal wall. As the testes and their associated structures descended towards the scrotum during embryonic development, so the ductus deferens, vessels, and nerves descended with it. The stalk of the processus vaginalis then usually regresses, leaving behind a closed sac. The testes pushes into this sac and it forms the tunica vaginalis. Deep to the visceral layer of the tunica vaginalis is the tunica albuginea. This layer surrounds the long and highly coiled seminiferous tubules that are responsible for producing sperm. The seminiferous tubules are joined together by the straight tubules, which themselves join the retir testes. Here the sperm leaves the testes to enter the epididymis. The epididymis is an elongated tube on the posterior surface of each testicle. It stores and allows the sperm to fully mature. The epididymis is then continuous with the ductus deferens, which delivers the sperm to the ejaculatory ducts for ejaculation. The ductus deferens initially runs alongside the testicular artery, pampiniform plexus, and numerous nerves within the spermatic cord to penetrate the anterior abdominal wall by entering the inguinal canal via the superficial inguinal ring. It then leaves the inguinal canal via the deep inguinal ring to cross the external iliac vessels and enter the pelvis. Here it runs along the lateral wall of the pelvis, deep to the peritoneum, and reaches the fundus of the bladder. Posterior to the bladder, the ductus deferens runs along the medial edge of the seminal vesicles, and it then dilates to form the ampulla of the ductus deferens. The seminal vesicles are a pair of glands located between the fundus of the bladder and the rectum. They are approximately 5 centimeters long and have the ampulla of the ductus deferens on their medial aspect. Each seminal gland is responsible for producing a thick alkaline liquid which has high levels of fructose that are important in providing energy for the sperm. The duct of the seminal glands unites with the ductus deferens, and this forms the ejaculatory ducts. These ejaculatory ducts pass through the substance of the prostate to open into the prostatic urethra. So each ductus deferens unites with the duct from each seminal gland to form an ejaculatory duct. These two ejaculatory ducts pass through the prostate to open on the seminal colliculus of the urethral crest. They then deliver sperm and semen into the prostatic urethra. From the prostatic urethra, the semen then travels through the intermediate and then the spongy urethra to the external urethral orifice. The male reproductive tract is associated with 2 important glands, the prostate and the bulbourethral glands. The prostate surrounds the neck and prostatic part of the urethra and is a firm walnut-sized structure. It has both a glandular part, which accounts for approximately 2/3 of the prostate, and a fibromuscular part that accounts for the remaining third. The outer fibrous capsule is dense and contains the prostatic plexus of nerves. Traditionally, the prostate can be divided into numerous lobes, with these being named according to the urethra. So there is an anterior and posterior lobe, and 2 lateral lobes, but these aren't overly important here. The prostate does release prostatic fluid into the prostatic urethra via those prostatic ducts. Remember, these lie either side of the seminal colliculus and drain into the prostatic sinuses. This prostatic fluid accounts for approximately 20% of the seminal fluid and has a role in sperm activation. The final gland I want to mention is the bulbourethral gland. These are 2 pea-sized glands that lie lateral to the intermediate part of the urethra within the external urethral sphincter. Their ducts actually pass through the perineal membrane and open into the proximal part of the spongy urethra. So to finish the podcast, I just want to finish by detailing the female reproductive organs. The female reproductive organs include the vagina, uterus and its associated uterine tubes, and the ovaries. So to start with the vagina, this is a musculo-membranous tube which connects the cervix of the uterus to the external environment. It opens into the vestibule, which is the space between the 2 labia minora. Also opening to this space is the external urethral orifice anterior to the vaginal opening, and the 2 greater vestibular glands. The vagina is an important structure in that it allows menstrual fluid to drain. It also forms the inferior portion of the birth canal and also receives the penis and ejaculate during sexual intercourse. Within the pelvis, anterior to the vagina is the urethra and the bladder, and the rectum is posteriorly. The vagina passes through the urogenital hiatus of the pelvic diaphragm. The walls of the vagina are usually collapsed, except for at its superior aspect, where it surrounds the cervix of the uterus, which creates a ring-shaped gutter. This ring-shaped gutter around the cervix, at the superior end of the vagina, is known as the fornix. There are 4 parts recognised: the anterior, posterior, and 2 lateral fornices. The posterior fornix is by far the deepest and is closely related to the uterorectal pouch. The cervix, which is the inferior third of the uterus, that protrudes into the vaginal cavity is a donut-shaped structure with a passageway running through the middle. This passageway allows the uterine cavity and the vagina to be connected, and this passageway is called the os. There is an external os which faces the vagina, and an internal os which faces the uterine cavity. The uterus, or womb, is a pear-shaped hollow organ that has thick muscular walls. It is the site of embryonic and fetal development, with the uterus expanding in size with the increasing size of the fetus. The non-gravid uterus, with a gravid uterus being one during pregnancy, is found in the lesser pelvis, with its body usually sitting on the bladder, and the cervix is between the bladder anteriorly and the rectum posteriorly. It is important to appreciate, however, that the uterus can assume a number of positions, especially in older postmenopausal women. The most common position of the uterus is often described as being anteverted and anteflexed. If the uterus is anteverted, it takes up the position like I described earlier. That is, the uterus is said to be anterior orientated relative to the axis of the vagina. If the uterus is directed more posteriorly in relation to the vagina, then it is said to be retroverted. Also, if the uterus is said to be anteflexed, it means the uterus is flexed anteriorly relative to the axis of the cervix. Conversely, if the uterus is posteriorly flexed, it is considered to be retroflexed. So the position of the uterus is dependent on its relation to the axis of the vagina, making it anteverted or retroverted, and also to the axis of the cervix, making it either anteflexed or retroflexed. To help you remember which axis applies to the uterus being verted or flexed, you can use the V from vagina to remember it's either anti or retroverted at the axis of the vagina. So V for vagina and V for verted. The uterus really has two parts, the cervix, which I described earlier, and the body, which includes the superior 2/3. The superior tip of the body is known as the fundus. The body is found between two layers of peritoneum, which forms the broad ligament and is highly mobile. The uterine wall consists of 3 layers. There is the outer perimetrium, which is a thin peritoneum-derived serous connective tissue layer. Then deep to this, there is the myometrium. This is a smooth muscle layer, and it contains most of the blood vessels and nerves that supply the uterus. This layer is responsible for contracting under hormonal control during childbirth. The final, deepest layer of the uterus is the endometrium. This is the inner lining of the uterus, which receives the blastocyst during implantation. If implantation doesn't occur, this layer is shed during menstruation. The supralateral regions of the uterine body are the uterine horns. This is where the 2 uterine tubes join the uterus. These tubes are usually the site of fertilization and are thus responsible for carrying the blastocyst to the uterine cavity. They extend from the uterine horns and open into the peritoneal cavity adjacent to the ovaries. As they extend to the ovaries, they lie in the superior free edge of the broad ligament. Each uterine tube can be divided into 4 parts. There's the infundibulum, the ampulla, the isthmus, and the uterine part. The infundibulum is the funnel-shaped distal end of the uterine tube, which are characterized by finger-like projections, the fimbriae, which spread over the ovary and collect the ova. Moving towards the uterus, there is the ampulla. This is the widest and longest part of the uterine tube, and is commonly the site of fertilization. The isthmus of the uterine tube joins the ampulla to the uterine horns. Running through the uterine wall is the uterine part, which is a short segment, and it opens into the uterine cavity via the uterine ostium. So each uterine tube is connected to the ovaries. The female ovary is an almond-shaped structure and is responsible for the development of the ova. They are suspended by several ligaments near to the lateral wall of the pelvis. Oddly, as the ovaries are suspended, they are actually located in the peritoneal cavity. However, because the fimbriae of the uterine tubes are closely associated to the ovaries, each ovum only spends a short time within the peritoneal cavity. So I mentioned that the ovaries are suspended within the peritoneal cavity by several ligaments. So to finish the podcast, I want to detail these ligaments and also explore the broad ligament. The broad ligament often causes some trouble, so I will try and keep it as simple as necessary when explaining it. But simply, the broad ligament is a double layer of peritoneum that covers the uterus and extends to the lateral walls of the pelvis. It is important in maintaining the position of the uterus. If you remember from an earlier podcast that detailed the peritoneal pouches of the pelvis, then you should remember the uterovesical and uterorectal pouches, found between the uterus and the bladder anteriorly, and the uterus and the rectum posteriorly. Well, these pouches are formed by the overlying peritoneum. If you imagine the peritoneum coming down from the anterior abdominal wall, it then travels posteriorly over the superior surface of the bladder and over the anterior surface of the uterus to form this uterovesical pouch. This layer of peritoneum then continues over the fundus of the uterus and also the uterine tubes, and then down along its posterior surface to then run towards the rectum. This forms the uterorectal pouch. If you imagine that this layer of peritoneum is then brought together either side of the uterus, these layers come together and form a double layer. This is the broad ligament which drapes down from the uterine tubes. Running in between this double layer is the uterine and vaginal artery and the venous network. The broad ligament itself can be divided into three parts. The majority of the broad ligament is the mesometrium. The part of the broad ligament that surrounds the uterine tube is the mesoalpinx, and the part that surrounds the ovary is the mesovarium. Laterally, the broad ligament extends to the lateral pelvic walls as the suspensory ligament, and these hold the ovaries in place, which also contain the ovarian vessels. Running from the ovary to the uterus is the ovarian ligament. This runs from the ovary towards the lateral edge of the uterus, just inferior to the uterine horns. So both the ovarian and suspensory ligament suspend the ovary. The final ligament I want to mention is the round ligament. This takes a similar path to the ductus deferens in the male, although it isn't its homologous structure. It leaves from the lateral edge of the uterus and travels within the broad ligament towards the deep inguinal ring. It then travels along the inguinal canal to exit via the superficial inguinal canal, where it blends with the fatty tissue of the labia majorum. So the broad ligament is a double layer of peritoneum that encloses the uterus and extends to the pelvic walls. It encloses the uterine tube in its superior free edge as the mesoalpinx, and also the ovary as the mesovarium. It is also associated with three thickenings. There is the ovarian ligament between the uterus and the ovary, and the suspensory ligament between the ovary and the pelvic walls. Finally, there is the round ligament, which travels via the inguinal canal to the labia majorum. So in this rather long podcast, I've detailed the urinary bladder and both the male and female reproductive organs. In the next podcast, number 5, I'll detail the rectum and the anal canal.